Real life.
Good evening, everyone. Welcome to another module of DOS PEP. And this time we are again come back with a lecture on DME. And after the first lecture by Dr. Raju, there was a lot of demand from students to have another class because DME is a very important topic. And we have a very, very expert in this field today, Ajay Aurora sir, which Dr. Ankur is going to introduce. So I welcome you all. And Dr. Ankur, please introduce our speaker for today, and then we'll move on for the class.
Okay, sir. So just sharing the. Good evening, all. Good evening, dear postgraduates. I welcome you all to the class 14 of our DOS postgraduate education program. To begin with, I would like to thank Dr. Lalit Verma, sir, who has envisioned the Retina series for the DOS PEP program, and Dr. Anupam Sachdeva, sir, for providing us with the umbrella-ship of ANBAI. The topic for the day is DME and its management. And to discuss this, we have a very eminent speaker, Dr. Ajay Aurora, sir. Dr. Ajay Aurora, sir, is presently the director of Vision Plus Eye Center, Noida, and a consultant at Cloud9. He is an alumni of JIPMER Pondicherry, and he did his ophthalmology, MS ophthalmology from JIPMER itself, where he received Thiru C.K. Kumaraswamy commemoration gold medal. He has done his Retina fellowship from Retina Foundation from Ahmedabad, and he's also received VR and IU inflammation fellowship from California, San Diego. He has more than 59 publication and is a well awarded and a person you always love to hear at various conferences with 260 presentation. He has received Joseph M. and Ula C. Lawrence Retina Research Award at Arvo, USA. He has also received AC Agarwal Trophy for Best VR Paper and another Asia Pacific Award for another VR paper. He has received GM Power Award in 2014 from VRSI, Natarajan Award at AIUSC. He has also received BMJ Innovation Award and have few patents to his credit. He is a life member of various eminent ophthalmological bodies. And when he's not teaching us, not looking after patients, he loves playing mouth organ and violin. With warm applause, I would like to welcome Dr. Ajay Aurora, sir. Over to you, sir.
Thank you. Thank you, Dr. Ankur. Thank you for those kind words. I'll share my screen. Is this visible and am I audible?
Perfectly audible and visible, sir.
So thank you, Praful. Thanks, Dr. Lalit, and thanks, Anbai, for the opportunity. Thanks the entire DOS team, and thank you, Anko, for those kind words. So I'll be talking today on diabetic macular edema management and overview, role of anti-VEGF, steroids, and some newer lasers. And what I will be actually be focusing more on things which I practically do. Some of the clinical trials I may not elucidate much because I think it's important for all of you to read up those trials because they are important and they can come as a postgraduate question. So basically, diabetic macular edema is an abnormal accumulation of fluid in the macula in the extracellular space. It is a chronic multifactorial condition. It causes visual impairment that critically impacts patients' quality of life. And the most important agent that is used are anti-VEGF agents. However, when we review the literature, we find that only 33 to 45% of DME patients show more than 3-line visual improvement with anti-VEGF, which suggests that there are multiple factors involved beyond VEGF that may be causative for diabetic macular edema. Now, in the presentation by the IDF, the number of diabetics between 20 and 79 years of age, we expected this number to be about 480 million, but it came out to be about 537 million people. 4 in 5 adults with diabetes live in low and middle class income countries. And diabetes is the cause of deaths in about 6.7 million people. This is the 2021 data. Okay, so diabetes in Southeast Asia is quite rampant, and as you can see, India as well as the countries surrounding it are massively involved. If we look at the progress of how diabetic macular edema or diabetic retinopathy has progressed in our country from 1999, you can see that the prevalence has overall rapidly increased. We now have about, in 2019, there were 77 million diabetics in India, and a figure recently came up that we have crossed over 110 million diabetics. Now, it's important to remember that though 1 in 10 people world over are diabetics, 1 in 18 may be having an impaired glucose tolerance, which means the actual diabetic load is much higher. As compared to the US, the proportion of diabetic patients in India is comparatively higher, and the management resources to us are quite limited. Hence, it is an unmet need. We must also remember that diabetic retinopathy, while we as ophthalmologists treating them, diabetic mellitus affects numerous target organs. It has got both microvascular and macrovascular involvement, and these must be kept in mind because the treatment of patients is very holistic. Now, the estimated burden of diabetes is high, and thus the burden of diabetic retinopathy and DME is equally high. Out of the total population, 8.3% of people have diabetes. 35% of these patients will have diabetic retinopathy, and of these, 7% will have DME. 40% of patients with DME will have associated visual disturbance. So it is important that as the diabetic retinopathy load increases, so does the load of DME, and so does the amount of visual impairment. The global estimates for diabetic retinopathy are, and this is data which is much older, but the trend remains similar, that globally 93 million persons have diabetic retinopathy, 38 million have vision-threatening diabetic retinopathy, 21 million with DME. So vision-threatening diabetic retinopathy involves two components: diabetic macular edema, because it reduces the vision, and patients who have proliferative diabetic retinopathy. There are 17 million of them who have proliferative diabetic retinopathy, where the vision will reduce either because of vitreous hemorrhage, tractional retinal detachment, or a combination of factors. And about 1.85 million people world over are blind because of diabetic retinopathy. Let us try to understand the pathogenesis of diabetic retinopathy. We know that there is loss of pericytes, there is basement membrane disturbance, there is a drop in endothelial cells. This leads to leakage and formation of microaneurysms. So the formation of microaneurysm is a hallmark for diabetic retinopathy. There is increased vascular permeability. Then you have vascular occlusions, which leads to the capillary non-perfusion areas on the angiogram, or we can demonstrate macular ischemia, and there is proliferation of new vessels and retinal hemorrhages. As the disease progresses, you can have contraction, you can have formation of new blood vessels, hemorrhage, scarring, and tractional retinal detachment. This is again indicative of how the retina swells up. There is accumulation of fluid in the retina, creating spaces which we call them as cysts. These are not true cysts. We could even call them cystoid spaces, but this is an intraretinal fluid present in form of cysts. And this, whenever cysts are present, that sometimes actually becomes an indication to use steroids. We will go over these biomarkers at a later time. So there is leakage of protein and fluid in the extravascular spaces, producing retinal edema, and there are retinal hemorrhages. And diabetes affects also the anterior segment, causing there is a rubeosus iridis, which can cause neovascular glaucoma, and there is proliferative diabetic retinopathy. Now, the aim of treatment involves to improve the best corrected visual acuity and reduce the central retinal thickness, and also reduce the complication of ischemia and neovascularization. So you have to do multiple things to achieve this. Not only inject anti-VEGF, but it is very important to have a good glycemic control the blood pressure. We must control patients' cardiac and renal status, and also reduce the lipids. There was a beautiful publication which came out many years earlier from PJ Chandigarh, which beautifully showed, after use of atorvastatin and reduction of lipids, how the diabetic macular edema gets controlled. So this is a complex chart which basically shows the various factors that are involved in diabetic macular edema, which indicates that there is a component of inflammation, there is increased vascular hyperpermeability. All these things is actually initiated by hyperglycemia. So in hyperglycemia, there is I will come back to these pathways again. So these pathways are involved in inducing the changes which we see in diabetic macular edema and diabetic retinopathy. Let me show you two small videos which will beautifully outline how does diabetic retinopathy occur. And I would recommend you people.
On entering the eye, light is projected onto the retina, where it activates the photoreceptor cells, the rods and cones. These photoreceptor cells convert light to electrical impulses that travel to the brain to translate into vision. Above the photoreceptors lie various layers of cells that include microglial cells and Muller cells. These are essential for the health and function of the retina. In the healthy retina, microglial cells are required for neuronal homeostasis and immunomodulation. In the normal resting condition, the microglial cells are activated to produce immunomodulators, such as interleukin 10, interleukin 13, interleukin 4, and are involved in the maintenance of homeostasis. Microglial cells also act as sensors for disturbances in their neuronal environment, contributing to neuronal protection and tissue remodeling. Microglial cell migration and transcellular passage by transcytosis is a normal physiological process. Muller cells support the survival of photoreceptors and neurons through maintenance of homeostasis, are responsible for the structural stabilization of the retina, and modulate immune and inflammatory responses. They can aid the guidance of light to the photoreceptors and buffer mechanical deformations of the retinal tissue. Neuronal activity of the photoreceptors leads to an increase in extracellular potassium levels. Muller cells take up the surplus of potassium ions via Kerr 2.1 channels and osmotically coupled water molecules via aquaporin channels to be released at fluid-filled compartments such as the blood vessels. Muller cells also perform numerous other functions, primarily aimed at supporting the survival of photoreceptor cells.
So when this goes altered, there's another small little video which will demonstrate extremely well what actually
This
happens.
imbalance causes fluid to accumulate in the retina, resulting in intracellular and extracellular edema. Hyperglycemia causes oxidative stress that initiates activation of the retinal glial cells to produce a number of inflammatory cytokines, including interleukin-1 beta, interleukin-6, TNF, and also VEGF. The upsurge of these cytokines attracts more cells migrating into the retina. Activated microglial cells proliferate and migrate into the subretinal space. As a result of abnormal transcellular channel formation in the diabetic retina, transcytosis of activated microglial cells is impaired and leads to accumulation of cells. The trapped microglial cells continue to produce inflammatory mediators that further amplify the inflammatory response and ultimately leads to disruption of the inner nuclear layer and neuronal cell death. Concurrently, the upsurge in inflammatory mediators and oxidative stress leads to dysfunction of the homeostatic control mediated by Muller cells. Cur 4.1 channels in the Muller cells are downregulated, leading to reduction of transportation of potassium ions from the Muller cells. Continued uptake of potassium by Cur 2.1 channels and osmotically coupled water molecules causes the cells to balloon, leading to intracellular edema and a loss of function of the cells. The intracellular swelling, edematous cyst formation, accumulation of extracellular fluid, and damage to microvessels may result in neuronal degeneration and photoreceptor loss. In addition, altered tight junctions of the RPE cells that can occur in the diabetic retina may cause subretinal fluid to accumulate as a consequence of Starling's law. Microglial cells secrete cytokines, chemokines, and neurotoxins in response to endogenous triggers in the degenerating retina. These increase capillary permeability and further amplify the inflammatory response. Continual dysfunction of the blood-retinal barrier allows leakage of fluid, proteins, and other macromolecules to leak into the retinal extracellular space, resulting in extracellular edema and macular thickening.
So this makes it very clear that there is an oxidative stress, there is increased vascular permeability, all because of hyperglycemia. There is edema of the cells within the retina, which then goes into the extracellular spaces, which become edematous, and that is how the whole process starts. So yeah, hyperglycemia is the initiator, and these are various pathways get activated. As you see here, we can see where do the steroids act and how does laser work. That works in cases where there is retinal ischemia. And where does the anti-VEGF work? That is because of VEGF production, and the other agents that may be utilized in cases of diabetic macular edema. Now, it is important to classify DME properly. When we were learning ophthalmology, we learned about the CSME, and this was typically the way we classified the central the macular edema. And now the classification has become very simple. The drcl.net has classified into a central involving diabetic macular edema and a no center involving DME. That means it is away from the central portion of the macula. Now, this is a central involving DME, which requires pharmacotherapy, and non-center involving DME requires focal laser. Why it is important? When we superimpose the grid, which you would have seen the ETDR as grid on the OCT, the central circle is 1 millimeter. That is the center involving DME. Then you have the parafoveal area and perifoveal area, and the parafoveal area, which is 3 millimeter and 6 millimeter. And these areas are the non-center involving DME. So if you have edema which occurs away from the center, and you have leaking microaneurysms, they can theoretically be treated by focal laser. And I'll show you some cases which have responded well to it. So this shows that if you have a patient like this, if you just look at a clinical picture like this without doing an OCT, you might find that this is a patient who does not have macular edema. But when we superimpose a grid on this, you can see here that there is a center involving diabetic macular edema, though the thickness is much more above it, but the center is also involved in these cases. Why should you try to recognize DME? Because it is the leading cause of visual loss in diabetic patients, especially in type 2 diabetic macular edema. And ETDR has 3-year risk of moderate visual loss in untreated DME is 32%. In the urban area, 1 in 3 DR cases will have DME, and in rural area, 1 in 5 will have DME. The treatment options that are available are we must identify DME earlier and must treat them early to prevent visual loss. Now, the things which I'll be covering in my presentation is metabolic control, control of anemia, anti-VEGFs, use of steroids like IVT, Ozurdex, suprachoroidal steroids, focal laser, peripheral laser, micropulse laser, combination therapy, blood pressure control, and surgical intervention. Now, metabolic control. This was a patient who came to us. Actually, this patient was slide was given to me by Dr. Mangar Dogra from PGI. So this patient had come who refused any intervention of anti-VEGF, and this is a slide which I have collected almost about 12 years back now. And he refused anti-VEGF. Anti-VEGFs had just come in place, and he did all his measures of diet control and yoga, and you can see the beautiful resolution of diabetic macular edema in these cases with disturbance of lipid almost about 6 months after he initiated in therapy, which basically means that if good metabolic control is initiated, good lipid control is initiated, it is extremely important for treatment of diabetic macular edema. So irrespective of the fact that you are treating any patient with anti-VEGFs or steroids or cases of proliferative diabetic retinopathy, metabolic control is mandatory in all cases. Similarly, control of blood pressure and hypertension and renal status is important. So this patient had come to me in Max when I was there, and this patient was approached us directly for blurred vision. He did not know that he is diabetic. So sorry, he knew he was diabetic, but he had never got an eye examination done. So he is a 48 years old type 1 diabetic, was on dialysis. When dialysis was given, the macular edema resolved beautifully. So it is important to treat the patient in a holistic manner. No anti-VEGF was given, and the patient responded well. So this is another patient who had come to us. This is a patient with anemia. She had thalassemia. She had undergone multiple injections of Subtenon Stricot, and also injections of Avastin, and her diabetic macular edema was not getting controlled. Obviously, it appeared to us that it was because of hemoglobin. We thought that we'll give Lucentis had come in the market at that time. This is in 2009, where the patient received intravitreal injections of Lucentis. But despite giving intravitreal injection Lucentis, the macular edema, but the central foveal thickness was still 400 micron. At this stage, we did not know what to do. So we decided, after a lot of consultation with different people from all over the country, I decided that we'll go ahead and do a vitrectomy in this patient, because there was no way we could increase hemoglobin. So this is a situation of a non-tractional diabetic macular edema where sometimes vitrectomy helps. So pars plana vitrectomy was done, and patient's visual acuity improved. It was done in one eye first, then the other eye, and patient responded well. So just to show that a vitrectomy can be useful in non-tractional diabetic macular edema, and anemia is responsible for producing macular edema, and it must be controlled. It is very important to control the blood sugar, and this just shows how by reducing hemoglobin A1C, one could modify the disease all over in the body, including diabetic macular edema and diabetic retinopathy. Now, what is the role of anti-VEGFs? Now, it's very important to look at the OCT. If you have a sponge-like edema, which is non-central diabetic macular edema, focal laser is done. Earlier, we used to do grid laser, but this is no longer done. When you have a cystoid macular edema, then anti-VEGFs are given. But whenever we have cystoid spaces, steroids can be used, and they're quite useful. When there's a taut posterior hyaloid, pars plana vitrectomy can be done. If there is a subfoveal serous retinal detachment without any taut posterior hyaloid, these patients should have a good renal control, good systemic control, and steroids may be useful. But with a taut posterior hyaloid, pars plana vitrectomy should be done. Please remember that in all categories, systemic control is mandatory. So OCT helps us to differentiate between a tractional versus a non-tractional diabetic macular edema. A tractional diabetic macular edema, it is important that we must do vitrectomy. We should not keep pumping in anti-VEGFs in these cases because they will not respond to anti-VEGFs alone. It's important to do surgical intervention in these cases. Just a few examples. This is a patient who responded well to anti-VEGF agents. This is a 52-year-old diabetic who had diabetes for about 10 years. The hemoglobin A1C was 7.2. This is the wide field angiogram. And this is the picture. How do we manage? There is some amount of subretinal fluid. Patient received Avastin. This is 4 weeks post Avastin. And this is after 3 Avastin injections, the patient did well. Now, these are older patients, older slides, which when Avastin was used. Nowadays, most of us use ranibizumab or biosimilars of ranibizumab or aflibercept or the newer agents like brolucizumab or Vabysmo. But this is just to show you that regular use of anti-VEGFs on a timely duration, which is on a monthly duration, actually works very well. In diabetic macular edema, the number of injections required are much less as compared to a choroidal neovascular membrane, and these need to be tailored accordingly. Now, this is just to show you that in these cases, it may be difficult to assess the retinal layers, even if you magnify them. So please don't worry, just give intravitreal injections, and this is how beautifully the patient has responded. Now, the management of diabetic macular edema with anti-VEGF, it's important to know which agent to use, and Protocol T tells us that this is an evidence-based management of diabetic macular edema. So this basically compared aflibercept versus bevacizumab, aflibercept versus ranibizumab, and ranibizumab versus bevacizumab. So it showed in patients who had lower visual acuity, that is less than 20/40 or 6/12, those patients responded better to aflibercept. Otherwise, there was similarity between bevacizumab, ranibizumab, and aflibercept. And at the end of 2 years, the differences between the 3 agents actually narrowed down, basically showing that these agents, depending upon the economy of the patient, any of these agents can be used, but if the visual acuity is less than 20/40 or 6/12, aflibercept may be preferable in these cases. So, Protocol T, around 50% of patients receiving aflibercept achieved a visual gain of more than 10 letters from baseline. It is important to remember that patients who start with a poor vision end up with poor vision. If they start with good vision, they end up with good vision. And poor responder, it is not necessary for you to convert from one anti-VEGF agent to the other. You could actually change over these patients to steroids, and we will see how does that work. Now, the association of central subfield thickness with baseline visual acuity shows that all these agents actually reduce the central subfield thickness. The maximum response is by aflibercept. The response of bevacizumab is also there, but it is not as good as ranibizumab or aflibercept. Now, I generally manage my patients of DME, and I imply the treat and extend regime, which basically means that you give an injection every 4 to 6 weeks, and later on, then you keep extending the period. And this way, we have seen that in the first year, you might end up giving about 5 to 7 injections. In the second year, the injection number reduces. And you must tell the patients that regularity of injections is extremely important. So the optimal dosing aims to achieve a balance between over and under treating. And diabetic macular edema, there's no urgency like in cases of choroidal neovascular membrane. Even if there's a little delay, it does not matter, but it is important to timely treat these patients. Now, it's been shown clearly that inflammation does play a role in cases of diabetic macular edema. If we look at various studies, they have shown that there is increase in vitreous levels of VEGF, ICAM1, IL-6, MCP1, And all these factors indicate that steroids have a role to play in these cases. This has been proven by a number of meta-analyses, and therefore steroids do have a role. Now, if we look at various biomarkers, one can correlate the response of these biomarkers to anti-VEGF or steroids. Now, if you look at this intraretinal cyst, if they are present, steroids are indicated. Hyperreflective dots are present, steroids are indicated. If there is a drill, again steroids are indicated. If there is a PVD, then again steroids are indicated. And in case of high levels of aqueous levels of the inflammatory markers, steroids are definitely indicated. So these are the clinical biomarkers of inflammation in DME, the hyperfluorescent diffuse diabetic macular edema, foveal hyperautofluorescence, hyperreflective spots, DME with cystoid changes, a neurosensory detachment, and an increased thickness of the inner retinal layer. So patients in which steroids are indicated or can be given at the first instance are pseudophakic patients, vitrectomized eyes, non-responders to anti-VEGFs, or rare cases of hypersensitivity to anti-VEGF agents. These are some examples of use of Ozurdex, a 57-year-old female type 2 diabetic, hypertension, which was controlled, pseudophaking in both eyes, has got a diabetic macular edema in both eyes. So this patient initially received an intravitreal injection of anti-VEGF, and surprisingly post-Lucentis, which is not a common observation, that the visual acuity actually dropped down, followed which patient received Ozurdex, the macular edema started getting controlled, the visual acuity improved, and same thing was given to the left eye. This is another patient who received multiple injections of Kenacort injection subtenos. This is an older slide, followed by also received focal laser and subsequently received Ozurdex, and 8 weeks post Ozurdex, the patient responded well. Now, steroids could also be injected in the suprachoroidal space, and I have a particular preference for this because I've been using a device which has now got patented with me, and I'll just show you some experience of using suprachoroidal steroids. So this is a suprachoroidal device in which, with a 30 gauge needle, steroids are being given into the suprachoroidal space. The moment we hit the suprachoroidal space, there is a give, and you can easily inject into the suprachoroidal space. The patient is absolutely fine. This is just to show you some examples. This was a 58-year-old obese female, diabetic, pseudophakic, had been lasered for proliferative diabetic retinopathy, and also had a cup disc ratio of 0.7 on anti-glaucoma medications. So she had received anti-VEGF injections, she had received Ozurdex, and when she came to us, this was a time when we had shortage of Ozurdex in the country. I told her about the options of suprachoroidal triamcinolone, and you see this response. This is before injection of suprachoroidal triamcinolone on the 14th day, on the 34th day, and on the 70th day. So the response is extremely gratifying, and it is cheap, and it works well consistently on all our patients. Now we are actually centrifuging triamcinolone, and this is giving us a response for almost about 6 to 7 months. A roll of lasers. Now here again, if you see that this patient who had extrafoveal macular edema, this patient underwent a focal laser, and this is 9 months post laser. So this is that this patient did not receive an anti-VEGF injection, just to prove that if the center involving diabetic macular edema is not there and you have an edema away from the center, laser is a good alternative in these patients. Sometimes you have cases whom you have treated with anti-VEGF and still they have a persistent diabetic macular edema, and you do a wide field angiogram and you find actually they have large areas of capillary non-perfusion in the periphery with leakage. So this patient was lasered in the periphery, and following laser, you can see that patient responded well. though those cystic spaces did not disappear, but they did reduce significantly, and the number of injections got reduced. Now, what is the role of micropulse laser? Before I tell you, what you should know is what is micropulse laser. Now, it's been shown beautifully in this seminal work, which was done by Mainster, that whenever we reduce the duration of a laser, one could specify the particular layer of retina where this laser would be effective. Like in this case, 1 microsecond, only RP is getting affected. Now, in micropulse technology, basically a continuous wave laser is split into on time and off time, and this leads to the laser being on for a short duration of time, like for a 5% duty cycle, which is for 200 milliseconds. The laser is on for 100 microseconds and is off for 1900 microseconds. So basically, that is the relaxation time, and this allows the tissues to recover. So whenever a micropulse laser like this is given, it does not cause any damage to the retinal tissue, and you cannot detect micropulse laser in the retinal tissue. But if some people have tried using subthreshold continuous wave laser, but that is not a micropulse laser because the laser is on for all the time. There is no time, which is a relaxation time between the on and off time. Therefore, micropulse laser is 100% tissue sparing. Now, multiple papers have come out which have shown the response to micropulse laser, and this was a beautiful paper by Wojciech, which was published way back in 2010, and it showed that not only micropulse laser improved the macular edema, but it also improved microperimetry in these cases. So we have a few cases which we have done with micropulse laser, and you can see here this patient who had macular edema, which was extrafoveal in nature. A micropulse laser was done. At that time, we were using a standard parameter. Now we use a test one and then treat these patients. And this is what the response was post laser, micropulse laser photocoagulation. This is another example of a patient who had proliferative diabetic retinopathy with diabetic macular edema. I have followed this patient up now for almost 7-8 years. And this was first treated in 2000, so almost 10 years now, first treated in 2015. And this is a regular follow-up on Octa in these patients. There is some increase in the macular ischemia, but overall patient is doing well. And this is just to show you that in the central portion, we do a 5% duty cycle laser, and in the periphery or mid-periphery, we use a 10% duty cycle. So we have also followed up the patient on visual fields, and we have been able to preserve the visual field of these patients on micropulse laser. Now, what is the role of surgery in diabetic macular edema? Whenever you have a tractional diabetic macular edema, it is important to remember that the treatment is surgical. Like in this patient who was managed by surgery, the macular edema gradually subsided. This is another patient where treatment was done. So this patient had been getting numerous injections of anti-VEGF, which is actually of no use. When he presented to me, we did an OCT, found that there was a tractional component. And once you treat the tractional component, the macular edema subsides. So this is how it is. Now, this is again to show you the role of micropulse laser in cataract surgery. So these are the important biomarkers which you must learn how to pick up: the central foveal thickness, drill, ELM integrity, ellipsoid zone integrity, presence of hyperreflective foci, and subretinal fluid. So these are the important ones. And this is just to show you what is meant by drill. There is a discontinuity of the layers of retina, which is basically the inner retinal layers. And this is what drill is all about. This is the paper. And this paper showed that for every 300 micron increase in drill during a 4-month period, the visual acuity drop could be predicted much earlier than actually when it happened. So therefore, it's important to see that if a patient has drill or not, because if a patient has drill, you can prognosticate the visual recovery of this patient once the diabetic macular edema is treated. The histopathological correlation of drill has been attempted, and it basically shows that drill indicates that there is a snap in the bipolar cell axons after the elasticity limit has been exceeded because of a persistent macular edema, and there is disorganization of the inner retinal layers. You remember the video which I showed you in the beginning, that how the communication of neurotransmission is impaired if there is a impair in the connectivity of various cells to each other. Now, a brief note about cataract surgery in patients with diabetic macular edema or in diabetes as such. The intervention depends upon the stage of diabetic retinopathy. So if you have no diabetic retinopathy or mild to moderate NPDI with no DME, early cataract surgery is indicated. But if you have a maculopathy, which is a gradable maculopathy, then you must treat this diabetic macular edema as per its merits. If required, if there's a tractional edema, then you could have a combined or a sequential surgery in these cases. If you have associated proliferative diabetic retinopathy, again, you can have a combined or a sequential surgery. So just to summarize, DME in a one eye and other eye has mature senile cataract, then you can give a pre-op anti-VEGF agents after doing a B scan to rule out a retinal detachment, and then go ahead and operate the cataract. But if you have a gradable DME, because the cataract is not so much advanced, then you treat DME and manage cataract after DME subsides. Now, in cases of gradable DME, as we have said, a non-center involving DME may require a focal laser, and this can be then later on, cataract surgery can be done after 6 to 12 weeks. And in cataract surgery, preferably use a larger axis, a hydrophobic, acrylic, monofocal, or EDOF lens can be used. Just to show you, and for the youngsters, that when we did not have anti-VEGFs available, so these are slides of 2005, when we were treating cases of PDR and DME, that if we treated these patients well, and like this is a sequential one patient being treated for PDR and DME with Kenacort and treatment of proliferative diabetic retinopathy. And at 15 months after we initiated treatment, patient underwent phaco, had a good recovery of almost 6/9 vision. This is similarly in the other eye of the patient. So we were managing our patients with a combination of Kenacort and laser, and it had reasonably good results. Right now, with availability of anti-VEGFs, the results are much better. If we do not treat our patients well, we can end up in a situation like this. This is 2 weeks post-cataract surgery. Patient was well-controlled diabetic, had normal lipid profile, had not been lasered, and according to the patient, fundus was not evaluated in detail. So this could land you up in medico-legal situations. So briefly, these are the URetina guidelines, and this is the guidelines which we presented in one of our ICs. So if you have a DME, which is non-center involving, if it is focal, do focal laser. If it is diffuse, were doing grid laser earlier, but now you could actually combine it with anti-VEGF and laser if required. Now, center involving DME, there's vision loss. Observe for 3 monthly. If vision falls or macular edema increases on the OCT, or if there's no vitreomacular traction, if there's no vitreomacular traction, then you follow it accordingly, as we've discussed earlier. If there's a vitreomacular traction, then we treat these patients by surgical intervention and treating them appropriately. So the key take-home messages are good metabolic control, anemia control, lipid control, and you must tell the patient to stop smoking. Anti-VEGF agents are the first line of therapy. Steroids have a significant role to play. Intravitreal corticosteroids act by their anti-VEGF property and by blocking inflammatory mediators. DEX implants are effective and show a favorable clinical response. Suprachoroidal steroid injections are showing good results and can be made to work for a longer duration of time, but it would require larger studies for them to become mainstream method of steroid injections. Traction DME needs to be operated. Focal edema needs to be lasered to reduce the burden of treatment. And supplementation of laser to the capillary non-perfusion area will help. Micropulse laser may reduce the burden of anti-VEGF injection, but still larger studies are required and regular follow-up is indicated. Thank you so much for the opportunity, DOS, for allowing me to present my views on management of diabetic macular edema. Before I conclude, this particular slide was there when I was preparing for this lecture. This came up. This was, I think, comment by Jocelyn. And this, when anti-VEGFs were introduced, it was such a remarkable event that he said, live so that you may profit from some new discovery. Thank you very much.
Thank you, sir.
I hope I have not overshot the time, 45 minutes.
No, sir. I'm just trying to ping Dr. Praful, sir. Anyway, sir, thank you for covering such an important topic with very, detailed series of case examples. And I believe the resident must be feeling much wise on these topics. And most of their queries must have been covered. However, sir, because we get questions online, and we have few questions which our residents have put for you. One such question is, sir, what is the central subfield thickness and vision for the endpoint of the treatment?
Sorry, Cedric, what is the
central subfield thickness? The resident asked what is the endpoint for the CST thickness and the vision when you're treating a patient of DME.
So whenever we have a patient of DME, it's been shown that if the central subfield thickness is above 310 microns, this can vary based upon various machines. But if you have a thickness of less than 310 microns, we do not treat them. If it is more than 310 microns, it is you could treat them. And there are various studies which have shown that if patient has good visual acuity, you can observe, like if a patient comes to us with a 6/6 visual acuity and has got a small cyst in the macular area, and the patient has a good vision, then these patients can be followed. But if the central macular thickness is diffusely more than 310 microns and the vision has dropped to less than 6/9, we go ahead and treat these patients.
Thank you, sir. Same person asked one more question is that what scenario would you consider switching between anti-VEGFs and what is the criteria one should use to guide their decision of switching?
So, as I showed you in the protocol T, that the anti-VEGFs which are presently available, like bevacizumab, which we normally don't use, ranibizumab and aflibercept. So, if you have a patient whose vision is less than 6/12, and you have initiated the patient on treatment with ranibizumab, in these patients, I would definitely want to treat them with aflibercept if the patient can afford it. If the patient has got good visual acuity, say 6/9, then it does not really matter whether I treat them with ranibizumab or with aflibercept. If the patient can afford aflibercept, then yes, aflibercept will be again my anti-VEGF of choice. And otherwise, we can go to either ranibizumab or Avastin in these cases. If the patient is not responding to, say, Eylea, and the patient has got evidence which shows that patient may have inflammatory component in the diabetic macular edema, like the hyperfluorescent spots, the cystic spaces, the subretinal space, and increase in the inner retinal layer thickness. And these cases, I would, rather than switching to another anti-VEGF, I'll switch to steroids in these cases.
Another question, sir, that says that does the duration of diabetes impact the response of anti-VEGF therapy? And are there any specific consideration for the patient with long-standing disease?
So it's very clear that longer the duration of diabetes, longer the chances of complications in a patient. If the patient, so one thing we must tell our patients, that they think that if you have started injecting anti-VEGFs, the diabetic macular edema will go away, and there will be a point where they will be absolutely fine. What you need to make them understand is that the diabetes mellitus is an ongoing process. The disease is an ongoing process. Therefore, the diabetic macular edema which the patient has is also an ongoing process. We may be able to control them adequately with anti-VEGF, with metabolic control, by stopping smoking and other agents. So in these situations, we must monitor these patients on a regular basis with the OCT and visual acuity. And I also try to monitor them with a home Amsler chart in these cases, because sometimes patient may not come back on regularly, so they can monitor at home with a home Amsler. It's a very nice small device which they can, and it's as accurate as an OCT. So I always tell my patients to have a home Amsler in case they detect changes after the Amsler has got sort of stabilized. And those cases, we tell them that they should come back and treatment must be given.
So there's another question that says that how does the presence of hard exudates near the fovea influence the treatment decisions?
So whenever we have hard exudates present next to the fovea, it's been shown that anti-VEGFs, because they respond very rapidly, they may cause migration of these hard exudates into the foveal area. If these hard exudates migrate into the foveal area, it can cause actually a drop in vision. So presence of hard exudates in very close to the fovea, to me, is an indication of using steroids. We have found that if we use Ozurdex in these cases, they actually respond slowly, they respond well. I always tell these patients that they should get the lipid control. Normally, LDL is supposed to be less than 100, but I tell them that if it is less than 70, then these patients actually respond better. And these days, ophthalmologists themselves can start patient on rosuvastatin. In case their triglycerides are raised, then fenofibrate can be added to rosuvastatin. So a combination of rosuvastatin or rosuvastatin F, as it is said, with the fenofibrate, if the triglycerides, which is very common in India, then it is a good idea to treat them with lipid-lowering agents and with intravitreal steroids, Ozurdex, or the suprachoroidal steroids, and they respond well.
The last question that I have for you for this evening is, if the patient has concurrent PDR with the DME, what is the preferred approach to manage the both conditions concurrently? You have just mentioned that in the talk, but still, sir, the question has come up.
Yeah. But so anyway, I mentioned this because the topic was not for covering PDR today. But basically, if you have PDR and you have DME, it is important that you do not initiate laser immediately. You should give an anti-VEGF agents which will help you control the DME. They will also help with the anti-VEGF agents which will control the proliferative component of the diabetic retinopathy. And once the anti-VEGF agent has been given, in about 3 to 4 days' time, you can start doing pan-retinal photocoagulation. In case patient has DME with a vitreous hemorrhage and you are planning to do a surgical intervention, then I normally give an anti-VEGF I would do a B scan to demonstrate any traction on the macular area. If there is a vitreomacular traction, I would give an anti-VEGF and within 4 to 7 days time, take up the patient for surgery. You should not delay surgery in these cases because sometimes if you have a tractional retinal detachment, it can aggravate because of contraction of the membranes. Therefore, any patient who has got a PDR, who has got a DME, either tractional or non-tractional, and you have decided to give an intravitreal injection, you have done the B scan, make sure that you have evaluated the patient systemically so that after giving the injection, you are able to schedule the patient for surgery. It is not that after you have given the injection, you realize you can't even schedule the patient for surgery. For example, patient may be on dialysis with heparin. So if your patient is on dialysis with heparin, we change them to heparin-free dialysis before we schedule them for surgery. So these are some permutation combination which you must keep in mind when you're treating a patient of a PDR with diabetic macular edema.
Thank you, sir. Thank you for answering all these questions. I hand over to Dr. Praful, sir, for any questions and for the certification, sir.
Thank you, Dr. Ankur. And sir, thank you. That was a wonderful talk. And I think student must have been very happy with this today's lecture. And Sunil, do we have that certificate with you? So, sir, this is a small appreciation from Delhi Ophthalmical Society. And at Bharat Mandapam, we will give you a frame certificate of this.
Okay,
From
okay. Thank
13
you
to
very
15 June. This is our annual conference, and I request you all the students. So please participate in our at our annual function, which is going to be from 13 to 15 June at Bharat Mandapam, and it will be our Diamond Jubilee celebration. So we are completing 75 years. So it's going to be a special occasion for us. So please do participate. And sir, I would like to request you to be there with us for those 3 days.
Yeah, must tell you that recently I was at Bharat Mandapam. There was this singer Kaushiki who sang the yesteryears, the divas of yesteryears, and I was amazed at the how beautiful Bharat Mandapam is. It felt like as if you're not in India when you're within Bharat Mandapam. It's a beautiful place, and everybody must come for DOS because you've selected a wonderful place for the conference. It's amazing, actually.
Thank you, sir. Dr. Ankur, I think we can conclude now. Just for a clarity, a lot of people are getting confused why there are only 4 people in the webinar. So, for speakers and panelists, the Zoom platform is there. For students, there is the YouTube platform, so Tech. For audience who are not students, there is the YouTube platform from DOS. So, basically, there are 3 platforms through which one can see our program. So, I hope this clarifies the doubt in the minds of students who were asking me since morning whether we should go for YouTube of DOS or for Tech. For all students, please go through the Tech platform. Dr. Ankur, I think we can conclude here.
Yeah. Thank you, sir. Thank you, Aurora, sir. Thank you, Dr. Praful, sir. Thank you, the technical team. Thank you, the postgraduates, for being there, for asking these difficult questions. Thank you, everyone. Have a great evening. Have a great night. And thank you for joining
Thanks,
us.
Ankur.
Thank you, sir, once again.
Thank you,
Good night,
Praful.
good night, sir. Good night, Dr. Ankur.
Okay, good night. Thanks.